Good evening. Welcome, and a particularly warm welcome to our guest speaker, Richard Horton. And it's great to welcome you this evening to this special event arranged by the University Strategic Research Group, bringing together colleagues from across the different disciplines across the university studying population sciences. So Richard Horton studied medicine at the University of Birmingham and qualified in 1986. He then completed his general medical training in Birmingham, moving then to London to the liver unit at the Royal Free Hospital. But then he changed direction. He joined the Lancet in 1990 as assistant editor, moved to New York as North American editor in 1993, and then 2 years later came back to the UK to become editor-in-chief. Richard's held a number of prestigious positions, amongst which he was the first president of the World Association of Medical Editors. He's an honorary professor at the London School of Hygiene and Tropical Medicine and the Universities of Edinburgh and Oslo, and he was a foundation fellow of the Academy of Medical Sciences. Richard contributes widely to a range of national and international bodies. For example, as chair of the Royal College of Physicians Working Party on Physicians and the Pharmaceutical Industry, as a council member of the Global Forum for Health Research, and as a member of the External Reference Group for the World Health Organization's research strategy. And in addition to all of that, he's published widely in medical and general press. In 2007, he received the Edinburgh Medal for professional achievements judged to have made a significant contribution to the understanding of human health and well-being. And in 2009, he was awarded the Dean's Medal from the Johns Hopkins School of Public Health. Those of you who know Richard will be aware that he doesn't avoid controversy. He's well known for tackling substantial, challenging issues, and we hope that this evening will be no exception. So Richard, thank you for joining us. We very much look forward to your lecture, Making Medicine Count, Why Medical Science Has Lost Its Way and How to Discover Its True Purpose. Richard Horton.
Well, thank you very much indeed. It's a real pleasure to be here. The last time I came to Southampton, the professor of medicine died shortly afterwards, so I'm hoping that I'm not bringing bad luck. And anybody remember Professor Ralph Wright? I remember him very well in my early liver days. There was a time when Southampton would make the splash headline in the Lancet. And let's just review what we were saying about Southampton in 1913, 100 years ago. The struggle at Southampton proclaimed the headline at the time. Why? Because a terrible Act of Parliament had been introduced that was going to radically transform for the better, so the politicians claimed, healthcare in the UK, the National Insurance Act 1911. So no change there then. What did Southampton have to say about it, and what did we think about Southampton's response? Southampton medicine back 100 years ago was uniformly lined up against this act and campaigned vociferously against the government to change its policies. And we wrote at the time, such harmony in the medical profession has never been known before in Southampton. A remarkable alignment against this political wound that was being inflicted by the government at the time. But then a terrible thing happened. There was a betrayal that took place. A great disappointment was in store. And our correspondent at the time wrote that I'm informed that the change of mind of a single influential man caused these valiant preparations against the bill to collapse. We went on. But fortunately, my Southampton experience tends to show that a good many medical men have injured their position and opportunities by expressions and conversations which have displayed more prejudice than sagacity. I'm sure it's very different in Southampton today. Indeed, we did end with a rousing call to support Southampton physicians, as we concluded that, as a rule, the medical practitioners of Southampton did their best for their patients, and that there was no fault to find. But and I'm sure this is still the case today, there were exceptions even in Southampton, as all, including you, knew full well. Now, how then do we judge how we're doing in medicine or medical research? Back then, 100 years ago, it was vaguely polemical literary pieces in our medical journals. But we all get judged in certain ways. I get judged by this dreadful thing called impact factor. Every June or so, these things come out, and there we go, there we are, we're behind this giant that is ahead of us, and we have to live with these ridiculous figures. I mean, they're utterly meaningless, they're manipulated by one and all, and yet our publishers look at these religiously and certainly judge me whether we're doing well or not by where we stand on these things. And in many countries of the world, I might say, if you get your paper, I'm sure it's not the case in Southampton, you don't pay any attention to things like citations and impact factors, but in many parts of the world, in China, for example, you get your paper published in a high-impact journal, you'll get tenure, you'll get money, fame, riches, who knows what. So these things do, unfortunately, matter a great deal. But you get judged too, and it's not very nice sometimes when you get judged. So here, I think, with last week's Times Higher results. Now, you're at 146. Don't feel bad about that. I went to the University of Birmingham, as you heard, and the University of Birmingham's there at 153. So you're much better than my alma mater, I must say. Congratulations on that. There are lots of ways that you get measured. Here's another one. This is from The Guardian. I think that Southampton comes in there at 24th. Very good. That was The Guardian results reported, I think, earlier this year. And there are international comparisons. You won't be able to read this, but you don't need to because you're not on it. Neither's Birmingham, I might say. This is a way that you can measure universities according to the employability of your graduates. So we have all these crazy metrics. The one I like the most is how much Vice Chancellors get paid. So the Vice Chancellor gets paid the most in the UK is Andrew Hamilton, whoever he is, at the University of Oxford. And he gets a whacking over £400,000 a year, but got no increase, you'll be glad to hear, on the previous year before 2011-12. These are the latest data that I could get hold of. David Eastwood, I should confess I sit on the council of the University of Birmingham. We didn't vote David's salary, but he gets £406,000, which is ridiculous since he's lower in the Times Higher league tables than you are. Because where does Don Nutbeam sit? Poor old Don. Oh, he's living in poverty by comparison, penury. You should be paying this guy twice as much as what he's getting. What are you doing? I mean, this is performance-related pay. Obviously, it doesn't apply in Southampton. Anyway, it doesn't apply in Birmingham either, I can tell you. But anyway, these are the league tables that we all have to survive, and it's crazy. Fortunately, and now the grovelling starts, we do have leaders who are there to put our case to government, to stand up for the profession, to stand up for education, to stand up for research. And your very own Ian Cameron is there to represent the Medical Schools Council, and congratulations on his appointment as chair. But sometimes universities go a little too far and go a little wrong. Here again is my wonderful University of Birmingham. Now, David Eastwood gave us a talk on council a few months ago, and he was talking about the current funding environment for research, about which I'll have a little bit more to say in a moment. And David's interpretation of what's happening to, and this isn't Birmingham, this is across all universities, when you do your sums and you look at resource flows going into UK universities at the moment, whatever you hear from government, ignore it, because the reality is we're talking about a 16.5% cut in the resources available to Birmingham. And what this has led to is some very perverse behaviour. Now, my friend, because I sit on the research committee there with Malcolm Press, who's the Pro-Vice Chancellor, who's responsible for research. Malcolm, lovely guy, but he unfortunately sent an email to staff boasting about how they managed to manage out underperformers. at the University of Birmingham? Well, as you can imagine, UCU, the University College Union, didn't particularly like this idea that Birmingham was managing out underperformers. So there was this huge fuss, and poor Malcolm had to backtrack massively and said that he'd been I love this. It was open to misinterpretation, he said. I'm not quite sure how managing out can be open to misinterpretation. Anyway, he said it was misinterpreted, and in fact is that his aim isn't to manage anybody out. My aim is to help people get back on track to satisfactory performance. But we all know, actually, that in many universities, the perverse incentives that we have does lead to really quite an aggressive approach to the way we handle the performance of academics. The environment is deeply challenging, and this is what I want to reflect on for a moment, because when you look at what is it like to envision a future career as an academic today, and this isn't particularly a medical academic, but an academic in a university, if you go and ask a population of young academics, do you think that you're going to have a future in this job? Roughly speaking, 3/4 of them say, yes, I definitely have a future in medical academia, whereas the reality is that probably fewer than half are going to have a future. So there is a big mismatch between expectations and reality. There is an unrealistic hope of an academic career. And is this good? Is this not so good? It seems to me that the current environment is not so good for young researchers who want to pursue a career in academia. And certainly when I talk to young researchers in Birmingham, there's actually quite a considerable fear about their future doing research. Indeed, Ian Chalmers, who you will all know very well from Cochrane Centre fame and James Lind Alliance fame today, led a charge of a group of academics who were criticising Liverpool, because not only are we subjecting the academic faculty to very, very stiff performance measures, but indeed non-academic faculty are also coming under pressure. And without non-academic faculty, we wouldn't have our universities. We wouldn't be able to do the teaching and the research and the administration that we so need to do. And in this particular case, Liverpool was being alleged to be losing almost 3,000 non-academic staff, gutting, the letter was arguing, the university of a vital support function. If we just step back and look at the UK higher education system at the moment, unfortunately, we have these kinds of headlines. Now, this is from March last year about facing relegation from the Premier League, and if you look at the results of the Times higher league tables, as much as you pay any attention to those, certainly in Birmingham we do all the time, they all get circulated to council members and everybody picks over them with great glee and fear. If you look at the results of the UK, there seems to be a bit of a gap emerging between a group of universities who seem to be holding up and doing very well and other universities who may be slipping back a bit in those league tables. Is that something we should be concerned about? Do we care about these league tables? Is it reflecting a kind of geopolitical shift in the nature of productivity from our higher education systems across the world? It's hard to know for sure, but there is a concern, because when you actually look at the departmental expenditure limits across government at the moment, across all of government, they're just over 8%, these departmental expenditure limits. These are the cumulative cuts since 2010 when the coalition government came into power. But if you look at BIS, where of course research sits, it's been almost a quarter cut overall in the BIS budget. Now, relatively speaking, the science budget has been ring-fenced to just over $4.5 billion. So in theory, we should be in a good place. But of course, thanks to inflation, the erosion of that has meant that we've actually had a 10% cut in our research budget since the coalition government came into power. That's not a political point, it's just a point. And it's a point that emphasises the environment that we are trying to do this work in. It is not an easy time. And then, of course, we commit massive own goals. I was in Australia in September last year, and I picked up a copy of The Australian, and there was this article, "The Visa Ban, a PR Disaster for the British System." I mean, there it says, it's a PR disaster because UK Board Agency has undone years of international marketing of British higher education. And that kind of message that we discuss here and then we send out and amplify to other markets is seen, of course, as a massive public relations coup. If you're running an institution, whether it's in Melbourne or Sydney, you've got a fantastic opportunity there to attract graduate students and researchers who would perhaps otherwise have thought to come to the UK, but now are going to be much less inclined if we have a very negative environment for them to work in. So not only are the signals not so great internally, but we're sending out not so great signals externally as well. And then you've got to, if you stand back and say, well, what is our productivity like? Now, the Nobel Prizes got released today, and 3 of them went to people studying all kinds of things I remember from my undergraduate days, but don't know a huge amount now, vesicle transport intracellularly. And if you look, and this is looking at Nobel Prizes being given to British scientists, 1 means that you got a Nobel Prize, 0 means that other people got them, but we didn't, and these fractions mean you shared them with others. And this particular paper, which was published in the economics journal, not a medical journal, was trying to suggest that maybe we weren't doing so well as perhaps we were a good deal of time ago. The kind of time when the struggle in Southampton was going on, as we spoke about just a few moments ago. Of course, what you've probably been doing is focusing a great deal on the ref, because the deadline's coming up, I think, at the end of November. So this is from the London School. I should say that I'm not making any undue disclosures here. My wife's a public health doctor and paediatrician, and she works partly at the London School and partly at St Thomas's. And this is what came round to her from Anne Mills. She's the Vice Dean at the London School, and this relates to the mock ref exercise. You've done a mock ref exercise, I take it? Yeah, absolutely. Ian said, yeah, very good, very good. And so what this mock ref exercise was all about was they didn't take 4 publications, they took your best 6 because they didn't want to have duplications when they make their final submission. And the amount of time, I mean, I don't know, I don't sit in a university, but I can only guess at the amount of time and effort and transaction cost that must be taken up by doing this kind of thing. Things that, time taken up when one could have been doing your own work or teaching or tutoring or whatever, but this incredible bureaucracy we've created around performance management is really, really quite remarkable. And this is certainly true at the London School, and I'm sure it's true here too. And when you look then at what's taking place in universities, it does begin to raise some questions about how we do measure you and what happens to you. So the allegation was that in Swansea, if you got less than a 3-star for your submission, then you were going to be shunted out of research and put on a teaching-only contract. So I've heard this story from many universities. Is this the right way to go, that we take research, teaching, divide them up and see them as 2 entirely separate initiatives? I remember when I was at medical school, and for a long time afterwards, and even today, that the interplay between research and teaching seemed, to me at least, to be rather important, and that actually integrating research and teaching was not a bad thing to do, it was rather a good thing to do. But we seem to be moving to a system where we're actually splitting off research from teaching because of these incentives that we put into the system. The way it was put by somebody at the University at Oxford was that a noose was being put around the neck of academic freedom. The reason being, in this particular case, that we now have this 25% of ref being allocated to impact, and this person saying, well, when I've been doing tutoring of my students, I hadn't even thought about impact, and so I gave all the credit away, and what I actually should have done is kept the credit for myself and not given any of it away so that I could put in a personal statement about my impact. Is this, again, this notion of impact, which on the surface seems to broaden the criteria, are there again unanticipated negative consequences from that? We are fortunate in that we do have bodies in UK medical science that can make a very, very strong case on our behalf. And before the last election, we had, for the very first time, the Academy of Medical Sciences publishing its own manifesto. not a party political manifesto, but a science manifesto, a medical science manifesto that it wanted political parties to respond to. And I thought that was a fabulous idea, that instead of just being passive recipients of government policy, we got out there and we fought our corner very, very directly with government. And I think the Academy did a very good job of trying to do that, and I hope they continue. Another way that we try and address these things is by attempting to have very broad strategies. These are the 5 key performance objectives, I think they call them, KPTs, key performance targets, that Birmingham has. And you can see that, yeah, absolutely at the top is enhancing our research power. But they are very concerned about enhancing student experience, because the National Student, whatever it's called, the NSS, is now a very dominant metric for universities to be considered, to consider. Sustaining financial strength, performance and status as an engaged university, by which I think they're talking about impact, broader social, societal impact, and be a destination of choice amongst our peers. In other words, attracting great talent, both in terms of research and teaching. So we try and create an environment where we, in a sense, not necessarily resist, but protect ourselves from the worst excesses of these incentives. But sometimes it goes really badly wrong. And I want to give you one example of a terrible example of where academic freedom was restricted and where a university found itself doing things which most sane people would not do. Queen Mary, University of London, found itself catapulted, surprisingly, in the last ref, and found itself in a very, very high echelon of leading universities. They hadn't expected it, but they suddenly found that that's what had happened to them. And having achieved this position, they were then desperate to hang on to it. How do they hang on to it? They thought, my God, we've got to manage out the underperformers again. So they then had this very, very aggressive performance management of their academics. And it led to, because they felt they had a very limited time to get this right before the next ref, coming up at the end of this year. So they instituted a program whereby they really, really looked to, manage out is a benign way of putting it, really fire staff based upon performance. And this led to a reaction. So one guy who's a professor in the School of Biological and Chemical Sciences, John Allen, he's a senior professor at Queen Mary, and he saw this going on, and so he wrote a letter to us. And now, I will admit, it was a little sharp. So he says, over in the medical and dental school, the Grand Inquisitor, so the person doing the performance management, is identified as the Dean for research, whose own research credentials are naturally unavailable for scrutiny. We hope to report back on our head's one-to-one interview with himself, he says. After all, we have his word, and that of the college senior management, that the restructuring is proceeding with complete fairness and transparency. Perhaps he'll use a mirror. So this was a letter laden with sarcasm, but was trying to make a very important point about the nonsense that was taking, in his view, the nonsense that was taking place there. The result of publishing this letter was that he was accused of gross misconduct and was dragged before a disciplinary tribunal, the end result of which would be that he would be instantaneously fired if they found against him. Rather than write back and engage in a public discussion and debate, the targeting of this particular professor was get rid of him. On any grounds, get rid of him. And I found myself having to go along to QMUL and give evidence on his behalf. It was a star chamber. It was the most bizarre experience. They had a group of people that they'd appointed, some from their equivalent of council. This was a non-transparent process. He didn't have any representation. He had a number of witnesses who he brought in. It was a very, very, very weird procedure. Unfortunately, they'd kind of over-egged it, the accusation against him, and so they could easily prove that he was not guilty of this. But nevertheless, this was the culture that was being created, and of course it was widely known throughout the university, and that is not a good result for the culture that one creates, a culture for scholarship within that setting, and it was not a good outcome. It's also concerning because it's unclear to me that when we go on talking about, and we certainly do this in medicine, we now can't mention the word health without mentioning the word wealth. It's the health and wealth agenda that we are participating in. We are going to deliver wealth to this country by investing in medical research as well as health. But it's not always clear whether that is true or not. This work, which I've just taken the slide out of, again, the Times High, which is a great source of this stuff, when you actually look at the correlation between graduates in science and economic growth, the numbers are all over the place, and it's not clear that there's a direct relationship at all. So the economic instrumentalism that tends to govern the way we make our case to government, it's not at all clear that that's right, and I certainly know many within the Academy of Medical Sciences are very worried that when we go into a comprehensive spending review and our pitch is that indeed it is wealth as well as health, and if that convinces government, they are going to expect a return on that investment they make in a relatively short time, certainly within a political cycle. And everybody knows that that isn't going to happen. We're not going to be able to deliver that return on investment so fast. So we're setting ourselves up for failure. We're claiming an expectation in government that we're not going to be able to deliver. This isn't great. And then Ian Chalmers tells us anyway that in fact our research system is full of waste. And on Wednesday there's a great anniversary celebration of the Health Technology Assessment Programme, but if you read Ian's work, he will tell you that the questions relevant to clinicians and patients, we don't tend to ask them. Are we implementing appropriate designs and methods? Often not. Are these results accessible for full publication? Usually not. And are they unbiased and usable reports? Absolutely not, because selective reporting takes place all the time. So we not only have all of these pressures, but when we come to actually report the research that we're trying to report, it often isn't great. So let's come back to the question. What is the purpose of a university? What is the purpose of the University of Southampton? Well, Kenneth Minogue, a well-known right-wing figure, philosopher, social scientist, wrote this book some years ago in which he made the clear claim that universities are not, you are not, devoted to the improvement of the world at all. And your attention should be remote from the urgencies moving men in day-to-day endeavour, was what he claimed. But if you look more recently at the literature, you will see that there is a sense of crisis within our universities today, much to do with the kinds of forces I've been mentioning over the early part of this talk. Stefan Collini put it very well. He's a professor in the humanities, when he talked about universities now having a disabling lack of confidence and loss of identity because of these forces that are shaping your behaviour, my behaviour in this system. Andrew McGettigan put it more directly when he said that we have these dimensions around us of activity that are really, he didn't use the word corrupting, I don't think, but are certainly damaging in the sense the moral fabric of what a university is there to do. Marketisation, commodification, independence from regulation, internal privatisation that's taking place in many of our universities, outsourcing of functions, corporate governance, and the entry of private capital into the higher education system. Now, I have no idea whether any of these things are taking place in Southampton or not, but they're certainly taking place in many universities, and I think it's an important debate that we have as a community as to whether we think this is a good thing for the university to do or not. And certainly in the university that I'm most familiar with, these things are happening, and many of us are deeply concerned about that. This political experiment, because that's what it is, must not reduce education to a commodity. The way we think about impact even is that what we're doing in a sense is we are using the measurement of impact to assert a bias without any particular evidence in its favour. We're asking people to make claims about their work, claims about impact because of the REF process, and are those claims truly justified? So let's just pause there, because what I want to do now is to say that I don't think we are in a very good place at the moment, actually, in our universities. in the way we do research. I think we actually are at a very significant moment where we have the threat of damaging in a sense, the social contract between the university and what it stands for and society. And we have to work very hard to protect what we've spent hundreds of years creating and strengthen it, not just protect it for the future. I don't claim to have any perfect answer to how we do this, but I'm going to give you one example of how I think research can be an enormous force for social, political good if we think about research as a global public good rather than a commodity that we're trying to measure in a marketplace of higher education. So I'm going to tell a little story now about work we've been doing over the past decade. It starts with this woman called Jennifer Bryce, who is a remarkable researcher who 10 years ago was working in UNICEF. And Jennifer came to see me in our offices in London. And I should tell you that although the Lancet, as you may know, publishes a lot of work in global health, I knew nothing about global health 10 years ago. I wasn't trained in it, I didn't know anything about it. And Jennifer came to our offices and she sat across the desk from me and said, "Richard, how much do you know about child survival?" And I said, "Well, I know nothing about child survival." And she said, "Well, it's outrageous that the editor of a so-called medical journal that has pretensions to be international knows nothing about child survival." And somewhat shocked that I was clearly on the back foot here, not knowing anything about this, I said, "Okay, so what do we do about it?" And she said, I want you to publish a series of papers about the current state of child survival across the world, and I want you to use the Lancet as a platform for making the case for greater attention to child survival. So, somewhat bemused by this whole process, I said, "Okay, well, let's try it as a little experiment." And she put together 4 papers looking at child survival. And at that time, there was something like 11 to 12 million children under 5 dying in the world. This is going back to 2002. And this is where they were dying, of course, a great concentration in South Asia and across sub-Saharan Africa in particular. But not just there. You will see pockets widely distributed globally. Each red dot represents 5,000 under 5 child deaths. So we looked at the evidence. We looked at what the evidence was, not just for where children are dying and what they're dying from, but we also looked at the evidence for what works in terms of interventions. Then they did modelling to look at what would happen if you scaled up those interventions. And then finally there was a call to action. So you have the scientific base that was presented, and then a kind of a political statement at the end saying, based upon the science, we recommend that policymakers take a different approach to child survival and place it much higher on the political agenda. What Jennifer did was she established a network of scientists around the world, not just in one institution, but she found the best scientists working in the best institutions to look at this utterly neglected problem. We published that series in 2003. And the result of that was that we then started getting inquiries about, well, you've done children, but that's under 5s. What about newborns? At that particular time, there were 4 million newborn deaths a year, totally, in the world, and newborn health wasn't getting much attention. So with Joy Lawn, who was at that time in South Africa, she's now at the London School of Hygiene, we did a series on the 4 million neonatal deaths and what were the causes of those. And many of these causes, of course, are entirely amenable to prevention and to treatment. So that series came out in 2005. What we then had was a body of work which was looking at the newborn and the under 5 period. And so we put that together by creating a group called Countdown to 2015. And Countdown to 2015 was a network of scientists that were dedicated to doing research, monitoring progress in child health, and then using their research and the monitoring of progress to make a statement about how governments, donors, foundations and others were doing in terms of their material, measurable improvements in child health. And so they produce this kind of profile. It's difficult for you to see this, I know, but basically what each little block is doing is explaining a particular metric and a measurement. So if I come down here, for example, this is in terms of pneumonia, antibiotics for pneumonia, oral rehydration for pneumonia, care seeking for pneumonia. Each of these represents a metric, an indicator for child health, and then the plan was at this time in around 2005 to monitor this every couple of years. This was, as I say, mid-2000s. Not surprisingly then, the maternal health community came to us and said, oh, here we go again, you're focusing on children, what about mothers? Because maternal health always gets missed out. And there is a tension between the maternal and child health communities. So we said, okay, let's embrace maternal health research and look at that. And of course, we know that the majority, when you look globally, of maternal deaths are taking place very, very early after pregnancy, after childbirth. So that series, which was led by colleagues at the London School, Una Campbell and Corinne Runsmans and others, when they looked at all the science, their concluding call to action was we need to expand and scale up services in facilities, facility-based delivery. What we had at this time now was a continuum of care, maternal, newborn and child. And so this network that had been created by Jennifer and then Joy and then the team at the London School, we had this network that was creating not just data, but new concepts in the way we thought about reproductive, maternal, newborn, and child health. And indeed, the reproductive part was very much missed out, because when you look at funding, of course, from the mid-90s, the purple triangles of funding for HIV/AIDS, we have seen a very, very welcome gradual and consistent rise in HIV funding. Of course, that is not so much the case now. But at this time, which is going back to the early mid-2000s, HIV was in the ascendancy. And if you look at reproductive health, here it was bumbling along and actually had been going down in the early 2000s. So a real attention away from reproductive health. So again, we tried to link the reproductive health community into this continuum of care. But then what we found was that as we were building this network that was getting bigger and bigger, other communities were joining. For example, stillbirths. Again, barely talked about in global health, actually barely talked about in our countries in high-income settings. But when you look at the toll of stillbirths, a massive, massive problem that needed to be brought to the centre of debate about RMNCH, reproductive, maternal, newborn and child health. And then you can go to the other extreme, because when you look at adolescents too get missed out of this. So this continuum expanding all the time. When you look, for example, so this is in boys 1 to 9, fantastic declines in mortality. Girls 1 to 9, fantastic declines in mortality. So that's a great success story. But here, look at the adolescent period, or the 10 to 24, it sort of goes beyond adolescence into young youth defined. Here for young men, here for young women. Basically flatlining. No significant gains in terms of, this is in terms of mortality for young people. And this feeling that we were not making gains in adolescent health has triggered, over the last few years, an enormous flourishing of research and advocacy for adolescent health, which is very good. And then, of course, what happened was that everybody said to us, well, you see women as just vessels for delivering children, but let's broaden the maternal agenda and make it a true agenda for women's health. And so we joined forces with a social movement, which is really what it was, led by somebody called Jill Sheffield, a series of conferences called Women Deliver. And indeed, the play on words was, women deliver, they deliver children, but women deliver much more than children, and it's what they deliver much more than children that we also need to be focused on. So women, yes, as mothers, but as individuals, family members, and as citizens, and thinking about a whole series of issues that are relevant for women and their health. Again, trying to create this really, really broad social movement for what is effectively women's and children's health. And now what we're seeing is, because we focused very much on survival, What are we saving all these children for? What's the point of saving all these children, or newborns, or preventing stillbirths, if we're not thinking about their development and the kinds of individuals they might be in the future? So what we're now working on, we've done 2 series on early child development and working on a 3rd for next year, is this idea that we need to think about the trajectories of brain and behavioural development over this early childhood age and what that actually means for their future. And of course, Southampton's been pivotal in the evidence it's provided. And I'm very sorry to be coming here so shortly after David Barker passed away unexpectedly. I can remember still very much David coming into our offices at the Lancet in the early mid-90s when I was an assistant editor in London. And this man was a force of nature like I've never seen before. I mean, he came in and you felt this guy was fighting the world because his work was being trashed everywhere. Nobody wanted to believe it. And he was fighting, it's wrong to call it an establishment perhaps, but he was fighting a body of opinion that was not receptive to his ideas. And the work of David, the work of many of you who've worked with David, and his legacy for the future is really thinking about what this future of early child development will be and getting children and young adults on a trajectory that can be transformative socially, politically, and even, I hesitate to say economically, but even economically as well. And then this year, bringing us right up to date, thanks to this global movement that's been created around nutrition for growth, we launched a series to coincide with a G8 meeting in May, June, looking at the contribution of maternal and child undernutrition to health. And the stunning finding in that work, led by Bob Black and others at Johns Hopkins, that 45% of under 5 mortality is the result of undernutrition, a huge problem that, again, we pay far too little attention to. What we've tried to do, so over this 10 years, is build up this big network, this big evidence base, connecting scientists together for science, for effectively political action, but also try to link this work with political events. So a year ago in the UK was the launch of what has been called Family Planning 2020, which is a global movement that's been led by the UN system in collaboration with the Gates Foundation and certain countries, in particular the UK, with a very specific interest in building advocacy to provide contraceptive services, contraceptive information to 120 million women who so far have an unmet need for those contraceptive services and information. And so what we've also tried to do is to link the projects that we've commissioned with these political events so that the evidence is there. We can literally hand it to policymakers when they come together, as we tried to do last year. So there's a very, very specific intent sometimes behind this work. Not only that, but the effort is to try and provide evidence not just at the global level for decision makers, but also to people in countries to show what happens in terms of lives saved when you add incrementally interventions together. So this work was led by Zulfi Bhutta, who's at the Aga Khan University in Karachi and in a whole bunch of other places as well. Zulfi is a very prolific individual, and what Zulfi showed is how when you add a series of interventions here, the contributions of the deaths averted as you keep adding these interventions, the sequential effect. So it's not just one intervention that you're adding, but when you build a package of interventions, in this particular case for pneumonia and diarrhea, you really can have the most transformative impact on reducing mortality. The message that comes out of this for me is it's all about a network of partners working together. It's not one institution, one university, or one journal, or one funding agency. It's a partnership, a collaboration between this enormous group. It involves UN agencies, it involves universities, like the London School, it involves civil society, it involves organisations like DFID and USAID. It's a remarkable collaboration. Forget the fact that this is about maternal, newborn and child health for a moment, and imagine this in any other area, whether it's non-communicable diseases, health systems, neglected tropical diseases. one could imagine this kind of collaboration with science at the centre, but science not on its own at the centre, building up this kind of collaboration. Because there is this larger political process that I think we as scientists and working in health research need to be much more aware of. When Ban Ki-moon, in reviewing progress on the Millennium Development Goals, said, time is passing and we must urgently accelerate our work, the question was, how are we going to do that? And what he created was what he called a global strategy for women's and children's health. And that was launched at the UN General Assembly in 2010. And the truth is that as a world, we're doing well. Here's the decline in under 5 mortality since 1990. But we're not doing as well as we need to be to get to the Millennium Development Goal target by 2015. When you look at the causes of deaths, again, many of these are preventable. Preterm complications, pneumonia here, big chunk of neonatal deaths, and as I said before, 45% associated with undernutrition. When you look at maternal health, it's even worse. Yes, there have been declines, but we're way off target for where we need to get to in terms of maternal mortality ratio. There are now, thanks to the science that has been done over the past 10 years, and absolutely not just us, but a massive movement around science for RMNCH, there is really the hope that the science is giving us an indication of what we can achieve. This is the decline in under 5 mortality, and this is where we will get to by 2035 on current rates. But the science we have tells us that we can actually take a very different path. We can really substantially reduce preventable childhood mortality really considerably better than if we carry on this business as usual track. The reason why we know we can do that is because of the science. It's the same for maternal mortality. We know that we can bring maternal mortality down to 2035 much further than we think we can today. There are now, again, thanks to the science, commissions that are making recommendations about delivering key commodities for women and children. This is the Commodities Commission that was released, co-chaired by Nigeria and Norway, released last year, making recommendations about the distribution of key maternal interventions, newborn child and reproductive interventions. And these are now being scaled up aggressively over the next 2 years to the target date of 2015. And because all these people are now making promises, and we've got the science that is helping countries and partners deliver this evidence for action, we're now creating systems to monitor accountability, to say, are we doing as well as we can? And science is really essential for that. So science isn't just delivering the evidence, it's also delivering the tools by which we can monitor progress. And there's Zulfi Bhutta, who's on this group called the IERG. It's the Independent Expert Review Group for Women's and Children's Health, which is monitoring progress around women's and children's health. And again, as I really want to stress how important science is, but not science for publications for the ref, science with a very explicit social objective. So let's just come back to this social objective. And this guy, Ernest Boyer, wrote a very important book way back in 1990 called Scholarship Reconsidered. And in this book he talked about 4 dimensions of what we all do in this academic community that we live in. There's a scholarship of discovery, and that is straightforward research, what we all talk about every day and what you're submitting for the ref. There's also the scholarship of integration. So by that he's talking about how we bring different disciplines together, and I've already, just in the few hours I've been here, the word multidisciplinary in Southampton has been beaten into me, and I can definitely get the feel that this is a place where multidisciplinary research has a very, very high priority amongst the leadership here, and rightly so, as Ernest Boyer was stressing. But also a scholarship of application, and not just impact in the ref, but really thinking about how work can be translated into social policy in a very, very direct way. That is something that should be recognised, it should be rewarded, it should be incentivised in our universities. And finally, please let us not forget, he argued, teaching. Teaching is not an add-on, it is something that's absolutely central. And this is where I think the separation of research and teaching, which we're seeing in some institutions, is a very, very dangerous thing. So 3 conclusions. First, science is globalizing like never before. This research published in Science a couple of years ago emphasized how the very best science today is not done in one university. It is done across university boundaries in multi-university collaborations. It's the fastest growing type of research, and it is also the research that is delivering results which are often of the highest impact, and I don't mean the impact that's being measured at the end of November. And what's very important here is to see the way this is shaping university behaviour, because we are seeing universities differentiate into different categories, and only some universities seem to be contributing to this globalization of science. So it's very important that universities that you and I are involved with think very carefully about our position and how we promote these kinds of global collaborations and how we reward those and incentivize those. A second conclusion does relate to education. And Lincoln Chen and Julio Frank is the Dean at the Harvard School of Public Health, there he is, did a commission for us a couple of years ago on health professionals for a new century, in which they talked about a slow-burning crisis emerging in the education of our health professionals and health researchers. Because again, we put people into silos, we have very little interprofessional teaching and training, and the result of this is that we miss opportunities to have a very different approach to the way we ask and answer questions. If you mix, for example, the nursing profession with the medical profession, and you find the very best schools of nursing research, they are doing incredible work that you just simply don't see being done in medical schools, because the perspective of the nursing profession has something incredibly important that we in biomedicine often forget about. And we can talk about some examples if you want later. So I think this notion of how important education is and the dangers that we have, especially in this globalizing environment, again, we have to think very carefully about. But most worrying to me is the way we do science. The way we do science today is it's closed science. We talk about a university that has disciplinary boundaries, often with short-term funding. The outputs that you focus on are research papers. The endpoints of those research papers are people like me at journals. It's often scientist-to-scientist communication. It's where scientists set the agenda, and the incentives, truthfully, lead often to paralysis. What I hope we can see is something very, very different. We see a new era before us of open science, where we're talking about plural institutions. That picture I showed of Countdown to 2015 partners. We're talking about addressing really important societal challenges. We're thinking about how we get longer-term investment in science. We don't just focus on research papers, and I'm saying that truthfully from the Lancet. Don't just focus on research papers. Think about other outputs that matter as well. Think about other tools than just journals, because we're not the best tool to create that kind of output that matters. Think about communicating to policymakers, not just to scientists. Patient and public involvement, PPI, setting the agenda as well as scientists, and lastly, creating a set of incentives that allows us to adapt to the challenges we face in societies across the world, rather than feel paralyzed or restricted or constrained in those societies. So here's the call to action. We need a new struggle at Southampton. That's what I hope we see in the future. Thank you very much.
Well, thank you, Richard. Now there's a challenge. We've got about 10 minutes for questions. Yeah.
All right. There's someone who's just in the real world outside academia, who's met a great deal of deceit in the medical profession. I find there's one thing doing science for research papers and for journals. There's a whole need of science between consultants and patients because it just isn't being done. The consultant reads the science journals, applies it to the patient without any consideration of errors of observation. The patient is actually a scientific experiment. When the patient presents a set of symptoms to a consultant or GP, those symptoms could mean anything, and you need the collaboration between the medical professional and the patient to actually explore which way those symptoms are going to go. And that doesn't exist. And I'm into that sort of thing because I got hit by a double-decker bus in 1991 and have lived with the side effects ever since. And there is a real problem between science in university and science at the coalface between patient, consultant, patient, GP, and that needs to change.
Thank you. I mean, one thing I fully agree with you. You definitely shouldn't read a paper in a medical journal and then go out and implement it the following day, or even the same day. You know, science builds on the totality of evidence, not just on one single study. And the whole system that we've created for scientific reporting, every paper that's published is like an event, whereas we need to think about the accumulation of research much more as a process. And I agree with you that we need to be very careful about how we use that evidence.
Dr. Horton, you suggested two things. One's a culture of scholarship and the other's a culture of collaboration. They're mutually synergistic, but they're sometimes politically quite suicidal. Now,
You have to explain that for
well,
me.
I mean, you know, if you're stuffed into a ref,
Yeah.
the quote from the man who encouraged his students and probably did a lot of good, but didn't write his own, wasn't focused on writing his own ref in.
Yeah.
Now, that's a continual tension if you're an enabling researcher,
Yeah.
both individually and between departments and between universities. And the structure that we have, political structure in universities, mitigates against that.
Yeah.
But we could do so much more if we could begin to think about changing the political structure.
Yeah.
And people like that, we can't change it as individual professors and individual universities.
Yeah.
But we could change it if the Lancet talked about trying to do that, if you produced your manifesto.
This sort of thing. Yeah.
Yes.
Yeah. Yeah. No, well, I mean, I produced the talk specifically for today, but you're absolutely right. I mean, I have spoken to various forums about issues related to this. I don't know what more we can do. I mean, I can write about it, but ultimately what it needs is a coalition between people like Ian as chair of the Medical Schools Council. It needs, yes, journal editors definitely coming together as part of that, Academy of Medical Sciences, Royal Society, Wellcome Trust, Jeremy Farrow's now at the Wellcome Trust. He's tweeting. You know, these leaders that we have, we need to come together and we need to say, this is not the structures that we want. What I find is too often when you do go and talk to people, there is a real fear about challenging these structures. Because what happens, and you see this at the colleges particularly, that if you challenge them, you challenge government, then you'll seem to be not on side and you won't get a seat at the table again. And that's certainly what happened with the Health and Social Care Act and why the colleges were so pathetic about addressing that. And that, I think, is where some of the concern comes here too. But I know that with Ian as chair of the Medical Schools Council, we will have a robust dissent.
Well, there's a challenge. Yeah. Good. David, yes.
Which country do you think does it best at the moment?
Well, that's a great question. Well, I tell you, my experience is that very few countries, high-income countries, do it well. And I actually think that many of the collaborations set up in low and middle-income countries do it much better. I don't want to name any one particular country, but global health research generally has taught me, and I think has a lot to teach us in the way research is actually done. And you know, the guy, Nigel Crisp, who wrote a book called Turning the World Upside Down a few years ago, I think encapsulated it very well, that we have a lot to learn from low, middle-income countries in the way we do things that we often don't learn from those countries. So I think that the incentives are much more, I find anyway, the incentives are much more aligned to societal and public health needs in those countries, whereas here, less so. I mean, I'll tell you, on Wednesday I'm giving a talk at this Health Technology Assessment Conference, and you know, where's health systems research in the UK? Seriously, where is it? It's nowhere. Whereas health systems, there's a massive movement going on out there in the world for health systems research. You'd imagine in the UK it doesn't exist at all. So that is, I think, where we can look with some care and attention and learn a lot.
So Hazel and then Mark.
So slightly changing the focus, you told us a great story about how child survival led to work in other areas. But the group and the whole women's and child health issue is dear to my heart. But the group you didn't mention at all was young men and fathers,
Yeah.
who seem to be a seriously neglected subject of study in
Yeah.
health. And I wondered if you had any thoughts about that.
Next series. No, you're right. It's funny, you know, because often what happens at meetings I go to on this, you know, lip service is paid to men, but sometimes the data works against this. We published a paper from Kareem Ronsman looking at, was the presence of a father important for, so looking at a group of children and what happened when the mother died or what happened when the father died to the outcome of the children. And basically, it was when the mother died, the child had a terrible outcome. When the father died, not much changed. So there is unfortunately, the data don't always support what I strongly, as a father, feel empathy with you about. But yes. I mean, too often men just sit around talking and they don't do anything.
So Mark and then a final question over there. Yeah.
Ah, you were in New York.
Yes.
Hello.
Thanks for the memories. So it's partly an MDG question, I'm afraid.
Yeah.
So thanks for the memories of David Barker. Been missed not just by us, we know. We sail very much now, as I'm sure Ian has told you here in Southampton, under the life course kind of flag.
Right.
And tried to make the argument that that will deliver all sorts of useful things, particularly in terms of economic output in the end. But it's not easy. And I just wondered what your thoughts were on the Eminent Persons report, which seems now to have more or less forgotten health, and to look 2015 and say it's all about poverty reduction. It's all arguably about money.
Yeah. So you mean the high-level panel of eminent persons? Yeah. But, yeah. So I think we're in a really, so if we now talk about global politics of health, just briefly, we're in a really difficult moment, a moment of acute uncertainty. We're moving out of the MDGs into the Sustainable Development Goals, and the whole concept of sustainability is so very different to the whole concept of poverty reduction. Poverty reduction is about people living in poverty. Sustainability is about all of us, not just one group of the population. It's also about future generations as being as important as the current generation. And it's also a challenge to the economics, because I'm not an economist, but talking to economist friends, everything about poverty reduction is about optimal economic growth to pull people out of poverty. Sustainable development is not about optimal economic, because often optimal economic growth in an era of sustainability is going to destroy sustainability. So sustainable economic growth is mutually exclusive from a macroeconomic policy focused on optimization. Now, that's work that's been done, published by Martisan and Sudhir Anand and others, very clear in the economics literature. So we're going into a phase where we're not clear on what the concept of sustainability is. People think health has never had it so good for the past 15 years because we had 3 out of 8 MDGs, and it's time for something else to come along, like education. Absolutely, all these other issues are very important. So how do we protect what we've had in the last 15 years and take it to the next level? So I think this is a really, right now, over the next 12 months, it's critical. We have to remake the case for investing in health. And on December the 3rd, in London, we're publishing a commission called the Commission on Investing in Health. It's a commission that's chaired by somebody who not everybody will like, but is politically a very powerful figure, Larry Summers, who has got a mixed reputation in some sectors. He chaired the World Development Bank report in 1993, which is why we're doing it in 2013, 20 years on. But his stature as an economist and his ability to open doors as an economist with political credentials, backed by a team of economists and health people, which is what we've got on that commission, is a very powerful force, we think, for restating the case for investing in health. So I'm actually hopeful that at the end of this year and going into next year, we'll be able to have the evidence in our hands to take to heads of state, which has not been provided by the high-level power at all. Nothing, as you rightly say. It's very superficial and really disappointing.
Final question, yeah.
Thank you. You've spoken quite a bit about sort of our interconnectedness and how to sort of make a greater societal impact. So going down that line of thinking, how do you see sort of academic involvement with the media in trying to kind of, as you say, spread this evidence, let's say, so through documentary filmmaking, sort of written news articles, etc.?
Yes. I think, people in health are often frightened to death of the media. But actually, and sometimes with good reason. But, in fact, let's think about it not just in terms of the media, but in terms of communication. Communication is a hugely neglected dimension of public health. And some of the reason why we've often failed to get our messages across and come across as this sort of nannying community that wants to stop people from having a good time, which is what many people say to me, is that we've not been very good about providing the evidence for how to communicate our ideas successfully. Communication has to be part of public health. And this is why I say we shouldn't be just thinking about, we published our paper in a journal, job done, let's move on to the next piece of work. We need to be thinking much more subtly about these issues of communication. The media is part of it, but it's much, much broader than that. So, yes, I agree with you. And we need to think about how we design research to do that. I'll give you one very, very powerful example that I know of at the moment, not done by people in a university. This is why I say universities have their role, but it's other partners. It's a little NGO called DMI, and what DMI does, sitting in a little office in Islington, is they are running a trial funded by the Wellcome Trust in Burkina Faso. And they have got this army of writers of soap operas. And so what they're doing is they are testing in a randomized trial to see whether in these stories on soap operas that are on the radio in different districts of Burkina Faso, whether in the intervention clusters, whether soap opera has all these messages about wash your hands, breastfeed, do this, do that, do the other, there's going to be a different outcome in terms of child mortality compared with those clusters where the soap opera doesn't mention any of these messages. What a fantastic idea that you actually use the media as an intervention, in an intervention trial. I mean, it's beautiful, but it didn't come out of university. It came out of somebody, the guy who runs this, Roy Head, was a BBC Newsnight producer many moons ago and then got interested in health. So, again, that's why these broad partnerships are so, so important, because they can give you ideas for research which people like me would never have.
So thank you. I think we should move on. And
Very
first
good.
of all,
Thank you.
many thanks for a tremendous presentation. We started off with the health warning for the Professor of Medicine, so to make sure that Ratco hears about that. We then heard about Southampton galvanising in 1913 and bringing the whole of medicine together, the unintended consequences of REF and the concerns about league tables. But then you sort of switched things and said, well, maybe there is something a bit more important. The key role of universities in research to inform policy for public good. The key role of universities to encourage and reward scholarship. And then that this will only be done not just by working across universities, but across the whole sector to build networks, bringing together people with different skills and abilities. So Richard, thank you for a very clear, lively and thought-provoking presentation.
Thank you. Thank you very much.
I think there is a well-earned drink and some nibbles outside, so please come and join us. Yeah, thank you very much. No, not at all, not at all. I quite like it. But I mean,
I'm not unaware Hello, thank you for your point. Sorry to hear what happened to you.